Welcome to Podcast UK.
Today we are speaking about the management of pharyngeal cancer and reconstructive surgery.
Hello and welcome to this episode of Podcast UK. My name is Matt Stone and today I have two excellent speakers talking about pharyngeal reconstruction. They are Mr Jemy Jose, a consultant ENT surgeon, and Miss Noemi Kelemen, a consultant plastic surgeon, who both work within the head and neck team at Hull University Teaching Hospitals NHS Trust. Welcome to you both. So what are the common presenting symptoms of pharyngeal cancer? And how do these differ between oropharyngeal, nasopharyngeal and hypopharyngeal sites?
So starting first with the general symptoms, and the general symptoms usually include weight loss, fatigue and pain. Specific symptoms include difficulty swallowing, hoarse voice, hemoptysis, difficulty and pain on swallowing and foreign body sensation. And then Mr. Joe is going to explain to you the site-specific.
So we are talking about nasopharyngeal, oropharyngeal and hypopharyngeal cancers here. So even from the patient's history, one might be able to have pointers towards where the problem actually lies in a specific subsite. For example, if it's a nasopharyngeal cancer, then the primary symptom will be nasal obstruction and epistaxis, as opposed to, say, if it's an oropharyngeal cancer, the primary symptom will be dysphagia, odynophagia, which is painful swallowing, and also referred otalgia because of the same nerve supply of the ear with the throat. Now, when we look at hypopharyngeal cancer, the hypopharynx being very, very close to the larynx, the primary pointers will be dysphagia, naturally, because the tumor obstructs the hypopharynx, and also laryngeal symptoms. So they will have hoarseness or have a speech abnormality. It is also important to know that in the United Kingdom, of the three cancers, oropharyngeal cancer is by far the commonest cancer. Nasopharyngeal cancer is very unusual, and hypopharyngeal cancer, even in head and neck context, is uncommon. So therefore, on a balance of probability, most symptoms will be of oropharyngeal cancer that patients will come with. Please also remember that the primary presenting symptom in particularly nasopharyngeal cancer will be lymph node in the neck or lymph nodes bilaterally in the neck, which is the commonest one of nasopharyngeal cancer. Oropharyngeal cancer also can present as a lymph node alone to begin with a very tiny primary. In fact, sometimes the primary is so small that it belongs to the realms of an unknown primary. For an unknown primary in the head and neck, as you might be aware, oropharyngeal cancer is the commonest subsite. Similarly, there is a very high presentation at the outset itself with a neck node in hypopharyngeal cancer. So always remember that lymph node enlargement alone can be the primary presenting symptom of all these three subsites.
Fantastic, thank you. How is pharyngeal cancer staged clinically and radiologically in the UK?
So the pharyngeal cancer staged according to TNM8 classification, and you can access these informations on the head and neck guidelines in the 6th edition. This is available on the BAPRAS website. As they are changing regularly, we would recommend you to look up the up-to-date classification before you go and take the exam.
Fantastic. Are there any general things that you can take from it, or you think you just have to look it up?
So in terms of staging, what is primarily changing in TNM staging is the oropharyngeal cancer. In fact, the hypopharyngeal cancer staging hasn't really changed all that much from TNM7 to TNM8. But as we will, I'm sure, during the course of discussion, we'll start talking about things like human papillomavirus, HPV, etc. You'll note that there is increasing changes in the staging system, in particularly oropharyngeal cancer, due to the difference in prognosis between HPV positive and negative cancers. Now, nasopharyngeal cancer has got a life of its own. Nasopharyngeal cancer has got its own distinctive staging. So it doesn't quite fit in with any of the standard cancer staging. Please read that staging very carefully in order to get a grip of what staging involves.
Great, thank you. So you've brought me on very nicely to our next question. So what is the role of HPV in pharyngeal cancer, and how does it affect prognosis and management?
So currently, HPV subtype 16 is prevalent in the UK population, and it's related usually to younger patients who are non-smokers.
So putting this into context, the head and neck cancers are a disease of low socioeconomic status, smoking and drinking. And that was the case with all subsites of head and neck cancers. However, what has happened over the last 2 decades or so is this noticeably increasing incidence of head and neck cancers in the Western population, including the UK. Although if you look at it, the amount of smoking particularly, and even drinking to an extent, has reduced. And the reason for this is really due to this, if you like, a newer entity in the course of history of human papilloma virus associated cancers. Now, HPV-related cancer can be there for any subsite. It can be there for oral cavity, oropharynx, larynx, any of that. However, the one where it is most relevant is for oropharyngeal cancer, i.e. cancers of the tonsil and cancer of the base of tongue. Those are the two main subsites. As Ms. Kelemen already mentioned, the difference is that unlike previously, patients who are non-smokers are generally fit and well, and younger people tend to get these cancers. And this group in general wouldn't even expect themselves or suspect themselves to have cancer. But now we are seeing a significant increase in that. From the treatment point of view, there is anecdotal evidence that HPV-related cancers in general have got better prognosis, and maybe, just maybe, treatment can be de-escalated for this group. The caveat is that even by anecdotal evidence, there is still a smaller group among these HPV cancers where the prognosis is in fact worse. So it's all about differentiating the two groups and also naturally differentiating them from the HPV negative group so that treatment can be tailored specifically for this group. At the moment, and we'll touch on this again as part of the discussion, research is ongoing to see what and how and whether de-escalation strategies will work, and results are expected for it soon.
Brilliant, thank you. Thinking now about the further decisions, what are the key considerations in multidisciplinary team decision-making for these patients?
So the key considerations include patient factors and disease staging. The comorbidities play a very significant role in determining our treatment plan. And once we have got the comorbidities and we have confirmed the TNM staging and the site of the cancer, including is it invading vessels, fascia, important structures around the neck, the lymph node staging, then we can make a common decision in the head and neck MDT, what is the ideal treatment for these patients. So as of for the workup for the head and neck MDT, one would require a histological diagnosis with biopsy, and we would recommend a CT skull base, MRI neck, and CT thorax, and CT head in the first instance. Usually the T4 cancers require PET CT scan for complete staging. Patients need dental assessment and a radiographically inserted gastrostomy, because quite often they will have difficulty swallowing, low nutrition, and any dentures which would require radiation later on, that can cause trouble and infections. So both of those things have to be done before the patient can proceed with any modality treatment, particularly focusing on radiotherapy.
So in general, like most cancers, smaller cancers need less treatment compared to advanced cancers. So same thing applies even in this one. So therefore, the early cancers, if you like, the T1, T2, N0 cancers, we opt for unimodality treatment. The modality might be just surgery alone or just radiotherapy alone. That's usually what happens to all these subsites. Of course, the advanced cancers will need multimodality, and the three modalities for head and neck cancer treatment is surgery, radiotherapy, and chemotherapy. So they need to be combined in different proportion depending upon the stage of these cancers.
Brilliant, thank you so much. Now moving on to think about the reconstruction. What are the main goals of reconstruction following pharyngeal cancer resection?
It's very simple. Speech and swallowing. Those are the two main aims. Basically, after resection and major pharyngeal cancer, we would want to restore a basically understandable speech for this patient and ability to be able to eat and drink, hence swallowing.
Absolutely. And that I agree, speech and swallowing are the main things we always aim for. You must understand that in a number of cases, we don't need to do any reconstruction at all. So, for example, oropharyngeal cancers, who the early stage, particularly when we do robotic resection or an endoscopic resection, they are left without any reconstruction. as opposed to if you're doing things on a salvage setting, that is patients who already had chemotherapy or radiotherapy, and then there is recurrence and you're resecting and then reconstructing, then almost always these patients will need some sort of reconstruction, no doubt about that. So those are the general principles around reconstruction.
Okay, so moving on to think about the specific reconstructive options then, and as Mr. Jose said, some patients may not require anything at all, but what reconstructive options are available for circumferential and non-circumferential pharyngeal defects?
So when you're thinking about the defect one has to reconstruct, you're talking about no reconstruction at all, and you would talk about pedicled or free flaps. When you're talking about pedicle flaps, the main flap we use in a workhorse flap is pectoralis major, with or without a skin paddle. We're talking about free tissue transfer. It's the radial forearm, the anterolateral thigh flap, the free jejunal flap, and the free colon flap has been used, or mental flaps, and also a gastric pull-up. So when we're talking about just non-circumferential defects, the most commonly used ones would be the radial forearm or a small anterolateral thigh flap or a pedicled flap, possible pec major. But if you want to tube a flap, you need to have the right size of the flap. So ideal flaps to create a circumferential new pharynx is usually the anterolateral thigh flap, and that's widely being used and it gives very good swallowing outcomes. However, free jejunal flaps and mental flaps have been used in these areas as well.
The main thing to understand about deciding whether the patient needs circumferential or non-circumferential defect in the first place is whether you can or cannot preserve at least a centimeter of normal mucosa after resecting the tumor with a clear margin. If it is possible to preserve 1 centimeter of mucosa, then it is always preferential to do a non-circumferential flap, wherein the swallowing will be significantly better any day than circumferential reconstruction of any sort. The circumferential reconstruction is more often than we like associated with stenosis and inability to swallow, etc. So hence the preference for non-circumferential defect reconstruction. That's secondly, as Ms. Kelemen mentioned, of all the flaps, if you want a circumferential one, an anterolateral thigh flap would be the best one to have adequate tissue. But if one is pushed for whatever reason, one cannot do it, or patient is not fit enough for, whether it is due to small vessel disease or anything, can't have one, then a pectoralis major flap can be rolled into a circumferential one. Or sometimes one does what called as a 270-degree reconstruction, wherein the flap is sutured onto the prevertebral fascia, so that the prevertebral fascia itself forms one or part of a wall, with the flap forming the rest of the wall. So that's another way of doing it. The centers all around UK, for that matter, around the world, have their own expertise in choosing a flap that they have historically or otherwise been doing a very long time. And therefore, each center will certainly swear upon their own modality of reconstruction as the best one. And there is no problem with that, so long as the outcome matches the expected standard. That's no problem at all. When you're talking about things like free jejunal flap, one should consider that it does add morbidity and mortality. For example, it means that opening up the abdomen, so that means there is an added issue of morbidity, and even, dare I say, in these unhealthy patients, mortality from having an abdominal procedure as well, at the same instance as having a head and neck procedure. Ms. Kelemen briefly touched upon gastric pull-up. That is, strictly speaking, it is not a reconstruction, but it is in those patients that have a large hypopharyngeal cancer, which may be extending down into the esophagus, going down into the thorax, for example, where one cannot really get to the end of the reconstruction with a flap. And that is the kind of stage wherein the best outcome might be, rather than trying to reconstruct it, to a total pharyngoesophagectomy and pull up the stomach into the neck and attach it to the base of tongue. Of course, it does mean that there is an added thoracic element and an abdominal element to the operation, which adds to the mortality and morbidity. And that also has to be taken into account when selecting the flaps.
Fantastic, thank you. This is more just for my own curiosity now, sorry, Mr. Jose, but when you mentioned about using pec major as a sort of an alternative option, does it mucosalize then?
Yeah.
It does.
Yes, it does. Yes.
You take a skin paddle with it, sorry, and then
You take the skin paddle, so the skin itself is there. But if you have a skin paddle left on, it is extremely difficult to roll it up. So if you have to roll it up into a circumferential one, then it is better to remove the skin and just roll the muscle and then do it, and the muscle gets epithelialized.
Wow.
And when we are making a circumferential pharynx, usually we use a Montgomery tube, and then there are certain tricks which head and neck surgeons use how to inset this. Basically, tubularize the ALT on the thigh, that's option one, and then you suture it in to the base of tongue. Then you can parachute it and tubularize it on the neck. So it is quite technically a challenging thing to actually insert these tubularized flaps into the neck. So there are certain technical tips which you can use to be able to stabilize the Montgomery tube at the base of tongue and then roll the flap around it. Some surgeons, as I said, tubularize it on the neck, and some surgeons tubularize it on the thigh.
Fantastic. Thank you. And thank you for satisfying my curiosity.
That's all right.
I just suddenly was thinking, I think we possibly have already answered a lot of the next question, but I'll ask it. And if there's anything else you want to add, then obviously you can. So what factors influence your choice of donor site for pharyngeal reconstruction?
We mentioned it before, patient factors and a tumor's size and site factors are important. And it's very important also patient preference. But I think the biggest challenge we have usually is the recipient vessels post-radiotherapy. And if we cannot find a recipient vessel, then we have to default onto a pedicle flap. And that is usually the problem when we have a salvage laryngectomy, is trying to find a vessel in a post-radiotherapy neck.
Yeah, absolutely. Many of these patients, as you know, they are smokers, etc. And most patients, almost by default, will have small vessel disease to a certain degree anyway. And it is a matter of choosing the best possible option under the circumstances. There are also some other factors you might want to consider from what we already discussed. Things like, for example, if you're talking about an operation in a woman, then maybe a pectoralis major flap is not the ideal one, because for one, harvesting the flap from under the breast, and also it will affect their own sense of appearance, etc. So that's one example of other factors that we need to take into consideration. Similarly, it also matters whether the patient had radiotherapy previously and how good or bad, if you like, the neck is, and availability of the vessels after the neck, because many patients unfortunately can have almost a woody neck, as we call it, where there are hardly any vessels available, and you really need to bring tissue from far elsewhere in order to reconstruct it. And if there are no vessels at all, then the go-to flap is a pectoralis major, because it's a very robust flap and it's pedicled. So therefore, that is really a very good fallback option in case free flaps is not available due to whatever reason, be it not availability of vessels in the neck, or whether it's due to microvascular disease, then that will be the go-to flap.
And the other thing is also the pedicle length of your flap. So you want to consider to see what kind of recipient vessels you can then explore on the neck. Consent patients for vein grafts, and sometimes we have used the internal mammary arteries as a recipient because they could be just quite difficult to dissect out. So basically, you just got to really think on your feet when you get the recipient vessels, and then you got to make sure that you got options of how to reconstruct it if you want to proceed with free tissue transfer.
And I guess that means you ideally need a very long length of pedicle if your flaps.
Not necessarily. So it all just depends on where you are in setting the flap, where your perforator will be, and how long your pedicle is. And the most common recipient vessels are the facial, we use superior thyroid, and sometimes the lingual, and then the transverse cervicals. And if none of them we can identify, then sometimes we go down to the internal mammaries. But if you want to plug anything down to the internal mammaries, you certainly need a vein graft.
Perfect. Thank you. So moving on to another one of the challenges with these flaps. So how do you assess flap viability and function in the post-operative period?
So the most important and most reliable method is the clinical assessment of the patient post-operatively. So their vitals, their lab results, their renal function. And then because these flaps are buried, there were some clinicians who leave out basically a skin paddle, which you can directly monitor. In our center, we don't use that routinely. We use a simple handheld Doppler and clinical assessment to assess the viability of these flaps. And also a telltale sign is usually the renal failure of the patient, the unwellness. So then we would then do a flexible nasal endoscopy and visualize the flap itself. We used implantable Dopplers in the past, The issue with them is in the head and neck, they are quite position specific. So quite often the implantable Doppler can show no signs and your flap is well perfused. But if you have inserted an implantable Doppler, we would recommend that if there's no Doppler sign, to take the patient back to theatre to assess the patency of the anastomosis. Anything else?
No, I think this is under the remit of plastic surgeons, so we just follow what is advised.
Fantastic, thank you. Moving on now to think about secondary procedures. What is the role of secondary procedures after pharyngeal reconstruction?
Well, we talked about the post-op monitoring, and then the secondary procedure would be in the immediate postoperative process. So the most two complications we would have to take the patient back to theatre for a secondary procedure would be flap failure or fistula. If the flap has failed, you have to make sure that the carotid vessels are safe and just basically make a decision with the patient and with the head and neck team. And you can then make a decision if you would like to do another further free flap or you would like to proceed with a petticoat flap. And that depends a lot from the patient factors and how the patient is.
Leading on from that answer, it is the second one which Ms. Kelemen said is about fistula. Now, of all the complication of a pharyngeal reconstruction, a fistula is the most common one, especially patients who had salvage surgery after radiotherapy or chemoradiotherapy. 30% or even up to 50% of those patients will have a fistula of some degree, which might not even be very obvious. It might just be a sinus which heals or an obvious fistula. So one needs to keep that in mind. Now, one of the factors what one learns over a period of time is the virtue of patience when it comes to repairing these leaks. To put it into context, most of these patients, dare I say every single patient, will already be compromised nutritionally. So if you check their preoperative albumin, etc., because the patient had dysphagia, odynophagia, etc., for a number of months, these patients haven't been eating or drinking. They tend to be smokers and drinkers, don't look after themselves, etc. So in general, wound healing is very poor in these patients, even at the outset. And doing more and more operations to fix holes is probably not the right answer straight off. So that is where virtue of patience come in. There used to be a saying in the textbooks, in fact, that one has to wait 40 days and 40 nights before repairing a fistula. That, in fact, is certainly true even in these days. Obviously, improving patients' nutrition, etc., has significantly improved over a period of time with our dietetic support. But what one must allow nature to contract the fistula and make it, smaller and more manageable size, and that only comes with time. And secondly, you need to have a reasonably healthy margin of the fistula to which you can attach something onto. So if all it does is every suture cuts through it, then you are as good as doing nothing about it. So these two aspects, the constriction of the fistula to a manageable level and being able to do something on top of it, just comes with time. So you do need to be patient about doing that. And once you know that, well, it is not going to heal after a certain time, then you have to make a decision whether one should go for free flap or another free flap if one was already used in the first place. And again, this is where a pectoralis major, well vascularized, robust, is a go-to flap for any salvage to close defects. So that's about the pharyngeal reconstruction after fistula. Then the other thing is about the aim of the reconstruction, obviously, to make the patient swallow well. And stricture of the segment is naturally something that happens, but obviously it's not an immediate problem. It only comes on a few months later or sometimes even a few years later. And again, one has to make a tailored step-ladder approach from the simplest thing possible to more complicated thing. The simplest thing might be to assess under a general anesthetic and dilate the narrowed segment to improve their swallowing. One has to be very clear in their own mind and also manage patient expectation as to what we can achieve. One should be very clear to the patient that he or she is unlikely to be going back to a normal swallow as they had preoperatively. And after many dilatations don't help, then you can even sometimes one extreme is to remove all your reconstructions and start all over again by putting in a new flap and hoping that the second group of reconstruction would fare better than the first one or not. So these are the factors that needs to be taken into account at that point.
Fantastic. Thank you. Thinking about outcomes now, what are the key factors that affect functional outcomes after reconstruction?
So we talked about the quality of swallowing, which is quite important. And as Mr. Jose mentioned, that managing patient expectations about the postoperative swallowing is a key for them to be able to regain a good quality of life. Speech quality is quite important, and it is important to appreciate that these patients will lose their voice once they undergo laryngectomy. So they will have to relearn to speak, and there are loads of devices out there. And we're also using, with the reconstruction, we primarily insert a device which actually will help with their postoperative speech. And then the further outcomes assessing is donor site healing, general quality of life, and then being able to get used to living with a tracheostomy. So if you think about you having a hole in your chest and breathing through that, that requires quite a lot of care. Just think about going swimming. So there is absolutely priceless work that the salt therapy team and the tracheostomy team are providing for these patients postoperatively. But overall, if they are engaging with the process, they can have a reasonable quality of life. Would you like to just talk about the little fistula we're inserting in between the neopharynx and then the trachea?
This is applicable to patients for hypopharyngeal cancer, not oropharyngeal and nasopharyngeal, obviously. So those patients who need hypopharyngectomy will also inevitably have their larynx also removed. In other words, it's a total laryngopharyngectomy that is performed. These patients need, in addition to swallowing, is also the speech rehabilitation that's important. One of the things which you do is it's called a primary tracheoesophageal puncture, wherein we create a fistula, a small opening between the tracheal stoma that you have created, the stump of the tracheostomy that a patient breathes through in the neck. From that, we make a hole all the way through the party wall between the trachea and the esophagus and insert a valve through it, such that after once patient is ready to go home or everything has healed, patient will learn to breathe in as you normally do through the stoma, and then when they breathe out, they either use their finger or these days there are hands-free devices to redirect the expiratory air through this fistula or valve into the esophagus and use the mucosal wave of the esophagus to create sound and be able to articulate with their tongue musculature. So that is the preferred and best rehabilitation in reconstructed patients. There are other ways of speech rehabilitation as well, but this is a surgical voice restoration procedure that we perform in these patients.
Wow, that's absolutely incredible. I've not heard much about that before, but that sounds amazing. So I think we've actually probably answered the next question, but I'll ask it. And if there's anything else you would add, but I think you've talked a lot about this already. So what are the most common complications specific to pharyngeal reconstruction and how are they managed?
So we talked about immediate postoperative complications, which would be a bleeding. That's like flattening usually in these patients, so they need to return to theatre immediately. And then we covered already the postoperative infections, saliva leak, free flap failure, sepsis, fistulas and strictures. So I think we covered that all in the previous areas, but this is the grouping part of it. Yeah.
Perfect. Thank you for that, Ms. Kelemen. And then that brings us on to our last question then. So we've flown through these. So what does long-term follow-up look like in these patients and how do you monitor for recurrence or late complications?
Well, I think Mr. Joe should take this question because it's usually these patients are followed up by the ENT team and by the ENT consultants.
So there is an established follow-up for cancer patients, be it reconstruction or not. They have a standard follow-up, which is there in the consensus document. So in a nutshell, in the first year after treatment, the patients are seen, say, 4 to 6 weekly at least, because the highest chance of recurrence of these cancers is in the first year, and therefore they need to be more closely monitored. In the second year, they're seen every 2 months or so. And from year 3 to year 5, they are seen anything from 4 to 6 monthly, depending upon how well they do. These days, people are trying other ways rather than all patients having to necessarily come to the clinic and be followed up using either phone calls or clinical nurse specialists or other auxiliary health practitioners using their resources in order to follow them up. And in a surveillance clinic, you only need to see those patients where either a recurrence is suspected or they're having trouble of some sort that needs intervention from one of the clinicians. So that's generally the follow-up done. The details are there in the UK head and neck cancer consensus document.
It is also important to appreciate that they need to have appointment with dietitians, salt assessment, salt therapy, then the rig feeding team, and also with voice restoration, they will need some help. So they will be seeing those specialists in between those outpatient appointments.
Fantastic. Thank you very much. So that's all of our questions. Is there anything else either of you think anyone needs to know with regards to pharyngeal reconstruction? Anything else that we haven't covered? I think we've covered quite a lot there, really.
Yes, so there is a very comprehensive document which we just basically talk through, which is Chapter 7, Reconstructive Considerations in Head and Neck Surgical Oncology. And this is available on the BAPRAS website and was in Head and Neck Cancer UK National Multidisciplinary Guidelines 6th edition. So it's basically one chapter, but it's actually a very well summarized document for further preparation for the exam.
Yeah, it sounds like that would be a great read for anyone listening to this who wants to further add to their knowledge that you have already spoken about.
Yeah.
Fantastic. Thank you so much to both of you for all your time and contribution to this. And it's been some really interesting things. I've learnt a lot. Thank you.
Thank you.
Thank you.
So thank you everyone for listening and goodbye. Podplast UK is a collaboration between UK and Irish plastic surgery trainees and consultants. The content reflects individuals' practice and opinions may vary. If you have any feedback, do get in touch. We hope that this has been interesting and useful. If it has, remember to follow us for future sessions.